Hello, everyone. Today we're going to be talking about a complicated subject, which is the hindfoot position in orthosis. I've got Simon Dickinson here with me from UK, who's got over 25 years of experience as an internationally well-known educator and clinician. And hopefully he'll be able to help us understand the subject a little bit more. We had a lot of comments underneath the post. Simon, what do you think about it? How can you help people understand the subject in general and what they should do in orthotics in general?
What they should do orthotics in general in a chat about hindfoot neutral is possibly slightly out of scope of this conversation, but yeah. I like the idea. I think, okay, so we're talking about something here which a lot of people have some really firm beliefs about. And we need to understand why people have those beliefs, and we need to understand and be clear about what we actually mean, because I think the terminology that we use as healthcare professionals around the world can be confusing. I think one person can say one thing and they understand it to mean this, and somebody else may think it means this. Well, they're different things. And I think that the standardization of terminology and the language that we use is really important. I think we also, as professionals, have some knowledge and some evidence about some things. We also have a large proportion of what we do, which we only have anecdotal evidence on. We don't have, systematic studies that allow us to quantitatively measure things. Partly because, particularly when we talk about AFOs, our patient variation is vast. So 2 children with cerebral palsy and hemiplegia who are right-sided and the same age can present massively differently in terms of their strength, their spasticity, their levels of function, their levels of cognition, as well as potentially anatomical variation. So let's start back at the original question, because your original question, and this comes back from Leipzig earlier in the last year, where I came and saw your fantastic scanning platform, which was mega clever. And you said to me, and then we positioned the heel in hindfoot, and I said to you, why do you want to do that? And that may make some people around the world who work in orthotics or orthopedics or neurology, affecting the foot and ankle, they may make those people go, oh my God, why? It's almost become a belief, a paradigm. Heels have to be straight. We live in a world where insole companies for many years have used an image of a flat foot and then a foot being straight on an insole as if it's cured the world, like a foot which is flat or pronating is somehow a disease that could mean you end up crippled and in a wheelchair. In fact, I've had patients tell me that clinicians have told them that they have flat feet, and if they don't get them treated, they will get disease in joints later on in life. And I remember one person telling me they might end up in a wheelchair. So we have to be really careful as clinicians that we see the world for what it is, not necessarily what we believe it is, or what we think it is, or what we're told it is. So the fundamentals of evidence-based healthcare are challenging the evidence. That's challenging the opinion. And as clinicians, we need to reflect on our own beliefs to see whether science actually backs up that belief. Okay, so the question is, do we need to correct the hindfoot to neutral? So let's go to anatomy first, okay? I have a skeleton in front of me. This is a plastic skeleton. It's held together by elastic. The alignment of this skeleton is variable. The shape of the bones are how they came out of a mold. It may or may not be a replica of somebody's foot. It's an approximation of a foot with the bones of it. So when we're talking about the hindfoot, we're talking about the calcaneum, we're talking about the talus, and we're actually also talking about the tibia. Now, this is the key point. A lot of people, when they talk about hindfoot, may just be talking about the calcaneum's position relative to the ground. Okay, so if we're thinking about neutral, what is neutral? Well, neutral is middle. Some people might think it's normal. But I think we have to be really, really, really clear. So I've done a couple of little slides just to kind of hopefully get this issue addressed. So if I share my screen, just can you see the slide that's appeared now with terminology issues? Great.
Yes.
Okay, so different people in different professions might think this terminology, excuse me, I've just got multiple screens going. There we go here, so I'm not confusing myself. So some people may think slightly differently. So if we talk about a neutral hindfoot, number one, are we talking about a patient standing, or are we talking about a patient non-weight bearing, and we're assessing what we think neutral is, whatever that is? We'll get to that in a bit. Or are we talking about a patient standing up, which in podiatric biomechanics is called the resting calcaneal stance position, and that's the position of the calcaneum relative to the lower leg. Okay, so we've got some issues straight away. Different people think different things about hindfoot being neutral. An orthopedic surgeon may view a hindfoot as being neutral if the heel is vertical or under the leg, equally weight bearing on the floor when the patient is standing.
And what do you think about it?
Sorry?
And what do you think about it?
Well, no, I think it depends when you're describing this. Why are you describing it? And let's be honest, why is it important? Okay, what we've been led to believe, and what many clinicians believe, is that the position of the heel relative to the ground is important. Okay, so why do people believe that? Well, some people believe that if your heel isn't straight or in neutral, they're probably different things, by the way, that you are somehow more or less likely to develop a problem. So let's just put neurology over there, and let's talk about a foot in a musculoskeletal patient. People have this belief that somehow if you're not straight, or so neutral could be your calcaneum and your leg are in the same plane, okay? That leg could have an element of varus to it. So that could be a neutral hindfoot. The ground and the heel could give you a straight heel up the leg. That could be a neutral hindfoot. Or if you look at Merton Root and the subtalar neutral generation from the 1970s, you have a position where you are palpating. I'll show you on my rubber foot. You're taking the foot in a non-weight bearing.
Sorry. If you want to show the leg, please stop sharing so we can see it better.
Oh, I'm stopped sharing. Okay. So if you have a rubber foot, okay, here's my rubber foot. Okay. So this rubber foot here, you can see a hindfoot. I haven't drawn a line on it, and there's a reason why. I'm going to come to that in a minute. This could be considered to be neutral or midline, whatever terminology you want to use. Now, if I take the leg and move it over there, if that's on the ground, the heel is still vertical to the ground. So that could be viewed as a neutral hindfoot relative to the ground. We have to be contextual here. If the leg and the foot are in the same plane, and you drew a line down here and a line down here, and they were in the same plane, you could describe that as hindfoot being neutral. But if your leg is in a position over here, because your patient has a significant tibial varum, or they have a massive genu varum, that leg coming in at the ground and the hindfoot being neutral, well, that has no real impact on the foot's ability to conform to the ground. The foot's primary function is to be our base of support and conform to slopes and surfaces and absorb load and generate forces to help with propulsion. So fundamentally, having the leg non-weight bearing to the ground, we could have a neutral hindfoot as described to the leg, but that has no real functional description whatsoever. Subtalar neutral is where you're palpating. Well, there's actually a number of ways of assessing subtalar neutral, but subtalar neutral is where you're palpating the neck of the talus, and then motion of the foot occurs until you have equal congruence between your thumb and your finger. That's deemed to be the position where the subtalar joint, the talus and the calcaneum, are neither supinated nor pronated, and then a load is applied laterally to the foot, so you can measure your hind foot to forefoot relationship, non-weight bearing, in order to prescribe things.
Sorry.
Sorry?
Let's say we palpated it and it's neutral.
Okay.
Is this where we want our foot to be?
Yeah, it's where the foot is when you do that test.
Yeah.
Okay. The big question really is, how reliable is that test?
Mhm.
Because when our discussion that we had over in Leipzig was about specification of an orthosis. When we are talking about, so to answer your question and go back to and answer it another way, are all human feet straight? No. Okay. Are all bones in the heel and in the talus and the tibia, do they all work the same? No. Are they all the same shape? No. So one of the analogies that I use is that from a learning point of view, it's really nice to have an idea of what we think average might be. And when we use the term neutral, we often, I think some clinicians use that as being what their belief of average is.
Mm-hmm.
So if you have 100 people in a room, they're not going to have the same faces. Okay, everyone accepts that. They're also not going to have the same feet. And their left foot and their right foot may have differences in them, but those differences don't make them abnormal. It's normal for them.
Mm-hmm.
So one of the good things about Subtalar Neutral and its education program is it allowed us to pick up some of the variations that do exist in the way feet align when you put them into a similar position. The challenge is that interclinician reliability for those tests is poor. Okay, that's proven. That's not Simon saying, I think clinicians are bad at this. I think some clinicians will go, I'm not having that. I've been doing this for 25 years. I've been doing it for longer. It doesn't make me an expert at all. But I can do this consistently time and time and time again. And the same person doing the same test on the same person can give you some moderate degrees of reproducibility.
Mm-hmm.
But if you take lots of different clinicians seeing the same patient, the interclinician reliability is poor.
True.
I can actually demonstrate that, because if I go back to my slides, I've got a couple of other slides just to kind of talk through while we make our way down this wonderful rabbit hole of describing terminology. So different people mean different things. What do I mean by hindfoot neutral? I describe that as a difference between a weight-bearing and a non-weight bearing position. And I prefer to use the term midline.
Okay.
And I do not take measurements.
Mm-hmm.
Okay.
Okay.
All right. I do not use a goniometer. I used to. I do not use a goniometer. And the reason for that is that there is a significant issue and significant evidence around subtalar neutral assessment, because I think that's what most people talk about in the orthotic world. They're palpating the neck of the talus. And if we look at the comments on LinkedIn from your original post, people are talking about putting the foot into a neutral position. Well, in the world of biomechanics, I think they're talking about subtalar neutral. But if you're having a conversation with an orthopedic surgeon, they might not be thinking about subtalar neutral. They might be thinking about a standing neutral straight position. Okay. So that's where we have to be really clear. So if you look at these studies, and some of them are really old. I mean, I could have added Hannah Jarvis's PhD here from 2017, done at Salford University, that showed that interclinician reliability tests using subtalar neutral methodology was significantly varied and unreliable, and that lots of tests weren't there, and that lots of people with no pathology presented with what were deemed to be abnormal findings using root methodology, things like a hindfoot varus, forefoot valgus. This is where the world's got a bit confused for me, because I don't think Root back in the day was describing that as abnormal. I think he was describing a variation, but we've taken that information and turned it into normal and abnormal. They did describe 3 normal events and then some abnormal events. I think in hindsight, if they were here now, they may say these are the average most common ones and these are the more unusual normal presentations. So that's where we need to go. So how reliable are drawing lines on the back of the leg? Well, if you look at Lapointe's study, which was a systematic review of the literature, you've got a variation of 3 to 6 degrees between clinicians assessing the same patient. And that level of variation, if we're prescribing an insole, could be a significant variation in the size of the wedge. So fundamentally, when we're drawing and trying to measure these angles, we are feeling soft tissue. There is fat, there is adiposity, there might be some other stuff that gets in the way, and then we're drawing a line and we're taking a goniometer, which probably only measures in 2 degrees increments, and thinking we can measure this. I remember being scrutinized at university because I was told something was 2.5 degrees, measuring it with a protractor that had 2 degree increments. Utter nonsense. We haven't got routinely in clinic the ability to measure these angles, and I don't believe we have consistent skill as clinicians to palpate and mark the same line on the same foot reliably.
I think there's even differences between measuring it day by day by one person.
But this is shown by the evidence here. So inter and intra tester reliability is not good.
True.
And if we're using this as the benchmark of having to decide how we position our orthosis or the heel in our orthosis, whether we should or we shouldn't, we are using measurements which are unreliable.
True.
Okay. And that have an error of 3 to 6 degrees. Now, some people, that is an average. Some people will be worse. Some people might be better. There might be some people who can nail it every time again and again and again. You are a god. Congratulations to you. I still don't think the measurement's important. And I'm going to tell you why. So, moving on. This is a study that was significantly overlooked and wasn't taught at biomechanics when I was at university. It was done by a doctor called Jan Bruckner in the United States. I believe it was done in Cleveland. And he did a dissection study looking at 32 cadavers. And he was interested in looking at the shape of the calcaneum and the talus, so their articular facets, and how they potentially moved. It was a more modern day version of work that was done back in the 40s and earlier. So this study clearly shows that the shape of the calcaneum is different in different people. Now, I was taught that the subtalar joint, so the calcaneum, the heel bone, and the talus that make up the hindfoot, that they touch in 3 places. Okay, and they rotated relative to one another in a triplanar axis. The subtalar joint axis sort of being this triplanar, I don't know if you can see, if I want to leave the slide up, but this triplanar position which the foot rotates around. Okay. What this study clearly shows is that a lot of people only have 2 articular facets on their calcaneum. That means that when this foot is loaded, the subtalar joint will behave differently. Because if the articular facets are different positioned and in different quantity, the axis of that joint will be different and the shape of the bones will be different. And if we're using the bones and we think we can palpate them through skin, and let's be honest, you think you can palpate them, yeah? If your life depended on measuring it to a degree, I'm not sure anyone would want to take that challenge. Because the researcher might measure it differently to you. So we have problems with that. But what we also have here is a different explanation. I have a number of pet hates that have developed over the years, and one of them is the word abnormal. I hate the word abnormal because I think it's vastly overused, and I think it has a negative psychological impact on the patients that we treat and their families. This study clearly showed that subtalar joint anatomy variation, osseous shape, varied in cadavers. That's normal. So if calcaneal hindfoot shape is different, and if it's different, it means they move differently, then having different foot shapes hitting the ground, feet which pronate or feet which supinate, is normal. It is normal variation, like there's 100 different faces in a room. And we have to get away from using this term abnormal. We also need to get away from other really horrible terms like this foot overpronates. How much is over?
Yeah.
It's ridiculous. Okay. So we have this fascination with the hindfoot. Okay, that's great. But the inconsistency of anatomy from Bruckner's study I've summarized here. We need to be thinking about these feet as normal feet. And if these feet are normal feet, the hindfoot angle in those feet will be different and is normal. So we're talking about patients here without neurology, okay, issues. We're talking about normal human variation, normal anatomy, and difference being present in a lot of people. Everything we have in our beliefs is based on an ideal that's simple engineering. Structures which are straight should be more stable than structures that are wonky. We are naturally wonky. So why are we trying to make naturally wonky people straight? Doesn't make any sense whatsoever. But the belief is that if you aren't straight, you are more likely to develop pathology and pain. Or as one of the commenters on the post on LinkedIn said, you are likely to develop more proximal issues as a result of a foot pronating. Well, that foot's always pronated in that person. It's their normal. And if you look at the incidence of injuries in semi sort of amateur runners, the incidence of injury is actually lowest in the group of mild pronators. Okay, feet pronating, they need to pronate. It's a facilitation mechanism for absorbing load. It's the ability's foot to handle that load that determines whether or not they get injured. So we focus on anatomy when we want to. And I think when we're going to talk about hindfoot position, we need to think about hindfoot anatomy. So here we have a really lovely set of pictures that highlight the complexity of the foot and the anatomy. And just so you all know, the anatomy of your foot is different. Okay, it's not just your bones, your muscles insert into slightly different places. Some of us have more bits than we should have. Some of us don't have enough. That's the way you are. You're born like that. That's your normal. It might not be what we think is average and ideal, but it's your normal. You're stuck with it. Okay.
Yeah.
So if we think about the hindfoot, and I'm just going to stop sharing my screen here, and we're talking about our fascination with the hindfoot. Okay. The hindfoot's the thing we load first. It is important. Okay. When we load the heel, the heel comes down and hits the ground. Okay. Boom. The ground produces an equal and opposite force, and that force is generated towards our center of mass, and it comes from the center of pressure. If that force passes through the axis of the subtalar joint will not supinate or pronate. If it passes medial, it will supinate. If it passes lateral, the foot will pronate. Okay, that's why feet pronate, because a force is applied to them. Okay. So if we think about this and we think about how the foot behaves and the difference between it being in the air and hitting the ground, when it hits the ground, a force is applied to it, which is external. There's an internal compression force as it hits the ground that generates an external ground reaction force that will have a certain magnitude and position and direction towards your center of mass. And that force will generate a moment if it doesn't pass through the center of rotation. It's basic physics. People assume that the subtalar joint then its motion is restricted by muscles, and it is partly. Okay, there are some structures around here which are ligaments that reduce and protect joint motion. They give us structural stability. But the functional ability for our foot and the speed at which it pronates is dependent upon multiple things: the size of the force, our natural bony anatomy, our subtalar joint axis location, the angle of the tibia relative to the leg. So if we're walking, our leg is relatively straight. When we're running, our tibia is more adducted. So there are variations in this. But fundamentally, when you think about anatomy and the control of the hind foot, the only muscle that inserts into either the talus or the calcaneum that can control and influence the speed of the foot pronating directly is soleus. Soleus's angular pull is coming in here, it's inserting onto this part of the calcaneum, and it's got a pull in this direction. So strengthening your soleus can reduce the speed at which your foot pronates. Tibialis posterior does not insert into the subtalar joint. It inserts into the midfoot in lots of different places. So tibialis posterior does influence the speed at which a foot pronates, but it does it by acting on the midfoot, not on the hindfoot. The rest of the anatomy that influences the motion actually inserts into the midfoot. And you can see that quite clearly on these images here. I don't know if you can see my mouse, but here's tibialis posterior coming in. You've got tibant coming in into the sort of the midfoot as well, all your peronei. The midfoot is where the vast majority of the muscles that give us stability for our foot, which are the long muscles, insert. Okay, there's obviously our long flexors and extensors as well, but they all cross the midfoot. So when we think about the position of the hindfoot and we think about the muscular control of the hindfoot or the functional stability of the hindfoot, this is a complicated thing, but there are no muscles that directly insert into the calcaneum. Okay, so you could argue that if you put this roughly in a position of midline when you were taking a mold, AFO or insole, that foot is kind of where it's naturally supposed to be. Okay, and the mechanisms we have for controlling it are going to work around that position. Okay, I'm going to go into a bit more detail on that because that will be a bit uncomfortable for some people.
Can I sum it up with one question?
Yeah.
So basically, correcting your hindfoot doesn't really influence that it's going to stay this way, because it's not how it ended up there, because only soleus is controlling it.
So putting a heel into what you think is a neutral position doesn't mean that your muscles will hold it there, if that makes sense.
Yeah, that's what I was trying to say.
So let's think about an analogy where this might be important. If you have a patient who has had a stroke, okay, a horrible thing to happen to somebody, and unfortunately it's left them with a hemiplegia. When we are designing an AFO for that patient, if you follow the paradigm of putting the foot in neutral or the heel in neutral, you are going to take that foot wherever it was and put it into your neutral, which might be vertical to the ground, vertical to the leg, or subtalar neutral. Okay, one of those three things, whichever one your one is. Okay, why are you doing that? Because I guarantee you that foot probably wasn't in that position before they had their stroke. All right. Now, their stroke may have influenced their supinators or their pronators, and they may have a pull in one direction. They may have a flaccid foot. They may have a foot where their muscles are working at different times, or they may have spasticity, hypertonicity, and it may be pulling their foot into a different position. If those muscles are pulling the foot into a different position, they're not pulling the hind foot because they don't insert into the hind foot. It's only soleus that's going to pull the foot into a certain position, and soleus hasn't got a massive lever arm. It's not going to give you a massively cavous foot. It would only do that in the presence of significant peroneal weakness. So changing the heel position based on spasticity doesn't make sense, because spasticity and weakness of muscles are going to affect the midfoot, not the hindfoot. Now, you can do some stuff in the hindfoot in terms of trying to change the way forces go through it, but the position of it is its natural resting position. And if you try to force it into a position that it isn't naturally in, so say you have a patient with a stroke again, and they have a significantly pronated foot, whatever the hell that means, okay? They have a flat foot, okay? Let's keep it really simple. And you straighten that foot in your AFO, okay? You just made that leg longer. You just made that foot and the bones of that foot so they're loaded in a way that they're not used to. Let's take another analogy. I remember being at a lecture with Simon Bartold, who's a professor of biomechanics. He owns Bartold Biomechanics. For anyone, I'll give you a free plug, Simon. Simon tells a story of an international basketball player with a foot posture index maxed out at pronation. Okay, mega pronator, mega over hyper super duper pronator. Okay, this guy had no pain. Was treated by somebody who gave him an insole because they assumed his foot position was likely to cause him a problem. And what happened? The basketball player with no history of injury got injured because his foot was loaded differently in an insole, and he should have been left well alone because it was normal for him. Alignment and injury are not correlated. Okay, there is a link to medial tibial stress syndrome in military recruits, but we cannot judge every decision we make clinically based on the alignment of the heel. It's far more complex than that. And putting a heel into a certain position that it doesn't want to go in might not be the best option. Okay, it might also be really uncomfortable. And if we're talking about insoles, and insoles being prescribed when we've got a heel which is pronating or everting, the evidence shows us that insoles don't predictably change the alignment of the foot. They massively change the load through tissues. And if we look at a study that was done quite recently and published, which was a meta-analysis of the literature looking at foot orthosis and position, it was done by a group of physiotherapists. This is the Des Terris study from 2019. That study, they were really focused on trying to prove that insoles didn't change alignment. And they did, because they don't predictably change alignment, okay? But what they didn't do was highlight in their study that insoles that are medially wedged significantly change the rate at which tissues are loaded and the speed at which feet pronate. So we don't necessarily have to change position to help a patient. We have to make that segment function so the tissues within that structure can handle the load. Simon Spooner describes it as the zone of optimal stress. It's a really nice concept when we're dealing with musculoskeletal patients. We've got tissues that are used to doing the certain thing in that person for a long period of time. They get injured because they have a healthy tissue that is loaded more than it can handle. Or they have an unhealthy tissue which is loaded and the unhealthy tissue can't handle the load. Okay, one of those two things happens. Our job is to reduce the load through the tissue. Okay, alignment doesn't necessarily correlate with that because we know from research with insoles that they don't predictably change alignment. They do sometimes, but actually they might not change alignment by a degree, but they massively change the speed at which that tissue is loaded. And if we've learned anything about musculoskeletal injury and the management of these patients in the last 15 years, it's that load management is the way we do these. We effectively manage these patients. We learn that patients, we have to manage the way the loads are applied to the patient, and we have to get them strong enough to handle those loads.
Okay, so we know now what not to do. We know now how not reliable. Oh, my English is gone. How we cannot trust the measurements we make. So what should we do?
Okay, so let's go back to the presentation, and we'll talk about that because there are a couple of other beliefs I just want to go through, and I'm being laborious here.
It's really nice you went so deep into the subject, but I think a lot of people at this point may be confused. Okay, what should I do then?
Okay, so is normal foot function best in a neutral position? Okay, so we have this neutral position. Do feet actually stay in that position? Okay. Or is it just a nice idea to help us understand how the world works? And then there is this belief that the subtalar joint's position has the ability to lock the middle of the foot and to stop it from moving. Okay, so just to quickly demonstrate that, the original concept for this was that if you took a foot and you put it into your subtalar neutral position, that would somehow make the midfoot lock so that the foot was a rigid lever for propulsion. So the idea being you hit the ground, the foot pronates, the foot then resupinates, the midfoot locks, the windlass mechanism kicks in, the first ray plantar flexes, and you have a rigid effective lever for propulsion.
Mm-hmm.
Is that true? No, it's not true. It's a nice idea. It's a simple concept. But again, back to the language that we use, is that actually true? And the reality is it's not. So this is a study that was done in 2008. It was an in vivo pin study. So essentially, somebody has surgically inserted pins into the bone of a normal person, and they have measured the way those bones move relative to one another during walking. This is Lundgren's PhD done through Salford University under the supervision of Chris Nestor. These results have been validated in further studies. What this study clearly showed was lots of stuff. Okay, this is, if anyone's interested in foot and ankle biomechanics, this is a paper you need to read, and you need to take your time to understand the statistics. Because down here, we have the average data and the standard deviations, the variations in the range of motion between bones in this study. Okay, and what it clearly shows, so calcaneum talus, this is the subtalar joint, the range of motion that occurs through that joint during normal walking is relatively small, with a low standard deviation, showing that it's got fairly consistent restriction in motion, not restriction in motion. It doesn't move as much as we thought it moved. Okay. At no point during these studies did the midfoot ever stop moving. It never happened. So you cannot say the midfoot locks, because this study proves it doesn't. It also proves that the subtalar joint did not resupinate during propulsion. Okay, that's really important, because one of our beliefs was that for the foot to be an effective lever to push off, it's because the subtalar joint resupinated and the midfoot locks. That does not happen. Now, a subtalar joint supinating or being straight does make the midfoot stiffer, but it can still move. Okay, but during propulsion, we do not get this position where the heel inverts, making the foot a rigid lever. We get stability of the midfoot through intrinsic muscle strength, and from these muscles creating functional stability, rotational equilibrium, so that the midfoot becomes an effective lever to push off. But at no point does it stop moving. So one of the arguments for hindfoot position is that you make the midfoot lock. That's not an argument, because it doesn't happen. Okay, and in normal walking, the foot doesn't resupinate for propulsion, so that doesn't happen either. Okay, so it's just another paradigm change and belief, and that takes us on to the what should we do, your question. Okay, and I think we need to first of all talk about what shouldn't we do. This is the work of Hilton Menz, who's a researcher from Australia. This was done in 1997, and it was done about foot orthoses. And his comment was that the literature, the evidence, the science we have based on clinical practice measurements is really unreliable. Okay, but we still place massive emphasis on it, on measuring these hindfoot angles, when we know insoles don't always make feet straight. There are some people in the world who are still trying to tell us insoles make feet straight. They don't. They might make them straighter, but the degree of correction in position is not correlated with a change in pain. Okay, we're trying to change the speed at which they move. Okay, So the result of taking these measurements is that if two people take different measurements on the same person and they're using those measurements to prescribe any orthosis, their orthoses will be different. And Hilton Menz, who is a researcher, states that those difference in prescriptions, and he was talking about foot orthoses, that variation is clinically unacceptable. Okay, and I totally and utterly agree with him. Because the reality is hindfoot variation in anatomy is normal. The angle assessment's unreliable. The midfoot doesn't lock and unlock, although having a foot which is straighter or more supinated can make it stiffer if you want to do that. Okay. Alignment and injury are not correlated. Changes in alignment don't equate with changes in pain. And putting the hindfoot in neutral does not stop the hindfoot from moving. So back to your question, what should we do? Okay. If we're thinking about insoles and we're thinking about feet which pronate that have pathology relating to the speed at which that foot pronates, then we need to slow down the amount that foot pronates. Okay. That doesn't mean we have to measure angles. Okay. What we need to do is always use a medial wedge, and we have to have a better understanding of the physics of how tissues are loaded and strengths and how that foot behaves. We need to know about the patient's range of motion, subtalar joint axis location, their muscular strength, and then design an orthosis that delivers the forces, or let's think of another term, the dose, the kinetic dose that is required to reduce the strain in that structure enough so that it can recover. And we also need to get those people healthy and strong. Okay, we need to not use language like abnormal. We need to understand this is their normal, and we need to address things that are focused on forces and not alignment when we're dealing with foot orthoses.
Okay.
When we're dealing with AFOs, we've got a slightly different scenario, because we're providing a patient with an AFO for one of two reasons mainly. Okay, one is pain. So we've now got a massive amount of evidence that offloading AFOs, things like the momentum, some of the carbon stuff going back to the Sarmiento AFO, can reduce the axial load, the compressive force through damaged joints for trauma patients and patients who have all sorts of arthritic degenerate conditions in their feet. Okay, for those people, the alignment of the heel doesn't matter. Okay, we want an orthosis that fits closely, and we want to reduce axial compression, load. Okay, we need to think about kinematics so that we don't adversely affect the knee and the hip when they're moving, but our primary design is force, and then kinematics comes second. The second reason why we provide an AFO is because somebody either has a weakness that causes them to have an instability, or they have a neurological insult that means that the control of that segment is adversely affected. And in those patients, we need to take a more holistic approach, and we need to ensure that our orthosis design allows them to have maximal function while trying to oppose spasticity or replace the function of muscles which are weak. We've got into a paradigm. Yes, it's really important. Alignment, shank alignment, massively important. Sagittal plane tuning, massively important. But just because you take a structure which is highly complex and wrap it in plastic does not mean it will not move. And I think we need to be thinking an awful lot more about midfoot control and about forefoot position when we're designing AFOs than we do in the heel. So, for example, one of the traditional tests for a supinated foot in musculoskeletal healthcare is the Coleman block test. You apply a block laterally, load the foot, and that lateral forefoot wedge will change the hindfoot alignment. If we have feet which are supinating as the result of weak peronei, we need to replace the function of the peronei. The peronei's job is to evert the forefoot by acting on the midfoot. We need to be laterally wedging these devices. The hindfoot will then find its own position, and we can try to resist motion by compressing the heel laterally, by applying a 3-point pressure system to that heel? Yes, absolutely. But measuring it, it's not really important. If we're dealing with the pronating foot and we're dealing with a child with cerebral palsy or someone with gastroc spasticity, then we need to allow the ankle to have a functional range if we can. And there's loads of really smart ankle joints now. So Fiora and Gens have got one, Becker have got one, Otto Bock have got one. We're not talking about that today, but allow those patients to have a functional range rather than free motion. Stop them getting to the point where their foot compensates for muscle tightness, but talk about supportive features within the orthosis to ensure that their foot is comfortable and can function. Trying to stop it moving is, you can't stop. You can't stop. It's going to move. And the position of the heel is there. So I would go so far as to say this. When I teach my students, and people are going to balk at this, when I was taught to cast an AFO back in the day, you would grab the heel, pull it straight, grab the forefoot, and try to line it up. Now, that's how a lot of people are taught to cast an AFO. How the hell at the same time you palpate through plaster or a casting material to know if you're in subtalar neutral is an absolute mystery. And anyone says that they can do it, I guarantee you can't. Okay? You think you can, and that's great, but you're palpating a position that is just really hard and unreliable to palpate without going through plaster in the first place or a scanning material. If you're 3D scanning it, then fantastic, you can get this foot into a position, but I would argue we need to be thinking about modifications like skives to compress the heel to restrict subtalar motion, wedges laterally, built into the thing. So our scanning platforms, if we're going to do them and we've got deformity, they need to be able to have medial and lateral wedges to be able to stabilize those, and things to help us have really high arch profiles if they're necessary, or for feet that supinate, something that allows the arch to drop, because who wants a high arch on a supinating foot? And we need to be thinking about the kinetic application of this rather than the position of the heel. When I teach people to cast AFOs now, I tell them to let go of the heel. I want them to control the foot in the position that they want it to be, and the heel will find its happy place. I then do put features in to hold that, and I do have things that close around it all the time, but I am not aggressively trying to force the heel into a position it doesn't want to get to, unless that patient has a massive hindfoot structural instability. So huge amounts of ligament laxity, perhaps injury to the spring ligament, and that's where I might do it differently. If I've got a rotation issue, a supinating or a pronating foot, I will try to overcorrect it rather than hold it midline. So if you've got a foot which is supinating all the time and you try to hold a supinated foot in an orthosis, then some comments in the chat, you should always use a lateral T-strap. I would argue, no, you shouldn't. I would be arguing you need to be generating lateral forces through the midfoot and the hindfoot, which is what the peronei should be doing, to try to give that foot intrinsic rotational equilibrium or stability, to try to make spastic muscles it harder for them to work and to create stability. Lateral straps in terms of cuboid straps, lateral Y straps inside AFOs, or even T straps in old calipers, they should be used when you have a structural instability, when that foot has no internal mechanism for stabilizing it and your functional forces, your external forces, don't overcome it. I used to say that if you prescribe an AFO with more than 2 straps, you designed it wrong. And although that is unfair, because there are patients who have gross deformity and tissue issues where we do need to apply additional straps, I generally think we need to be thinking far more about the forces coming from underneath the orthosis than trying to grip heels and hold them straight, because the science just doesn't support that our measurements are accurate and that those design features work.
I'm not sure if you're going to agree with my summary, but I think what you need to do is, first thing, examine your patient really closely. Decide what you need to do and what you want to do. and then read a lot of papers and learn so you can do it as well as you can, because no measuring devices will actually replace the knowledge and the ability to judge and assess correctly. Is that what you?
Yeah, and I think the other thing I would add with this is we're moving into a world of CAD now and 3D printing, which is going to make life better, more sustainable with a lower carbon footprint for people. Fantastic. I think we need to be thinking less about straight and more about, if I have a foot that pronates, why don't I take that heel and make it inverted in my orthosis? Why don't I give my foot a chance of not doing what it does for neurological reasons? I'm talking about AFOs now. Well, foot orthoses as well, actually. We need to, the whole principle that holding something straight means it stays straight is fundamentally flawed. If we have feet which supinate, I believe we should pronate them. Okay.
Mm-hmm.
We should be generating pronatory forces within our orthosis. There are some brilliant clinicians at the world who are phenomenal at prescribing insoles, and then they make an AFO and they're all flat. It drives me crazy that if we've got a rotational issue, a coronal plane issue, or a transverse plane issue, that we're prescribing straight orthoses, because they're not generating forces when they could be to assist the function. So if you're going to design a patient an orthosis and you're going to think about heel position, my suggestion would be, when you get that foot where you think you want it to be, that heel position's their normal. Okay, don't measure it. But if you want to try to design an orthosis to make that position more stable or protect tissues or whatever that may be, think about inverting it 5 degrees. I haven't got the recipe. Okay, it doesn't exist. But think about inverting the heel rather than leaving it straight. It makes no sense to leave it straight. Now, someone's going to turn around and go, yeah, but they'll grow an inverted heel. You would never provide somebody with an inverted orthosis unless their foot was rotationally unstable. And that means they've probably got spasticity or weakness. If they've got weakness, they're probably always going to have weakness. If they've got spasticity, they're always going to have spasticity. So let's try to find that balance. We've got a great understanding of sagittal plane control with AFOs. Amazing, really good research. Okay, we've now got really smart ankles that allow ankles to move. We've now got different stiffness with carbons and plastics for foot plate design. Ace, brilliant. Let's start thinking about coronal and transverse plane issues more. And let's start thinking about, actually, we can manipulate heels to help us, but we need to think about the midfoot and the forefoot an awful lot more than we currently do. Because I think that's where a lot of people are missing the trick. And that would be my summary.
Thank you very much. Thank you very much, Simon. If you've all came all to that point, I suppose we could probably record a few follow-ups, and there will be more questions and more questions. I hope there will be, because that's something people should talk about. So thank you very much for going through it, showing the biomechanics and then the anatomy that stands behind the why, rather than only, okay, let's do it this way because everyone does it this way. I think that's what orthotics needs.
I think that's really, really important. And I think for those people who disagree with what I say because their belief and what they've been taught, and sometimes people choose to read things that support their own belief, open your mind and just step back and go, is this the best I can do? Because it's not about how clever I am or how clever you are or how good your scanning system is. It's about how well is the result we give to our patients and how well do they do. And we need to make sure that our own opinions and paradigms don't get in the way of us trying to do our best and challenge the evidence. Because sometimes when you've done it a particular way for a long period of time, changing your opinion and your mind is a hard thing to do. Tony Blair still thinks they're weapons of mass destruction, by the way. He can't get over it. Apparently they're wrong.
I wish all patients, to all listeners, that they had such open-minded orthotists. And
I think we would provide better care, and I think that we would learn an awful lot more, and I think we'd get more things right than wrong.
Thank you very much.
No problem.